So how do doctors diagnose liver cancer? We can do some blood tests, we can examine you, and then usually, because most of the patients don't have symptoms, we will actually do some sort of imaging, an ultrasound, CT scan, or an MRI scan. We usually don't do biopsies, but it may become something that we do with newer treatments. But currently, we don't need to do a biopsy to diagnose it. And in the future, hopefully, we can do molecular testing for cancer. So I told you that liver cancer had a poor incident mortality ratio. Why? Because we don't have an easy blood test for early diagnosis. Most of the patients don't have symptoms, so most of them are diagnosed at a late stage. And if you're diagnosed at a late stage, we can't do curative surgery or other curative treatments such as surgery or transplant or burning small lesions. The other big problem that we can improve on is a lack of good drugs. The final reason is that most liver cancers, as I mentioned, occurs on a background of cirrhosis. If your liver is already damaged, then we're a bit limited in what we may be able to do because we don't want you to go into liver failure. This is different, for example, from breast cancer or prostate cancer or bowel cancer, where the rest of your bowel or your breast or your prostate, everything else is normal and you can just remove the organ. Whereas liver, we have to be very careful. If you've already destroyed 80% and you're going to remove the tumor and a bit of surrounding liver, we might push you into liver failure. So the key is to diagnose it early by knowing that you've got a liver disease and then trying to get curative treatments before you've got very advanced liver disease. So this is just a slide looking at the various treatments. So the first drug treatment for liver cancer was approved in 2007. It's a drug called sorafenib. And then we had a second drug over the last few years. And today in 2021, we've got sorafenib still. We've got another drug called lenvatinib. And the newest kid on the block is atezo-bev. And many people will refer to this as atezo-bev. This was approved in Australia in November last year. And then there's a few other drugs that we don't have good data for. But the three drugs that are available in Australia are sorafenib, lenvatinib, and atezo-bev. How do all cancer treatments work? And I think it's important for patients and their carers to understand cancer and to understand why and how we treat it. So if you think about a liver cancer or any cancer in any part of the body, so what happens is your cell first mutates and the genetics and the DNA in the cancer mutates, and then the cancer cell becomes fit to proliferate. In other words, this is what a liver cancer or a breast cancer is. They develop enough mutations in there to proliferate. So the cells become highly proliferative. And that's when you can see a lump. Now, the body obviously has an immune system that can look at these abnormal cancer cells, and they will try and kill those cancer cells with what we call immune clearance. Now, obviously, if your immune system is not strong enough, and the cancer also has mechanisms to evade your immune system. So here you've got 5 cancer cells. Your immune system can only kill 3 of them. So these 2 go on to multiply if your immune system is not as good. And then the last part of the triangle is for a cancer cell to multiply, it needs energy. So it needs calories to multiply itself. So when you think about 3 strategies to treat a cancer, is you've got multiplying cells. You can try and reduce the tumor burden by cutting it out, by surgery, by burning it, by freezing it, by doing a liver transplant, doing a mastectomy for breast cancer, or removing a prostate. Or if you want to try and use your immune system, You can give drugs that stimulate your immune system so it kills all of these cells. And today, the vast majority of treatments are based on reducing the amount of cancer and getting your immune system to fight the cancer. The last bit, which is trying to cut off the oxygen supply or the nutrient supply, the calories for the cancer, is we're doing it in a very mild degree currently by trying to block off the blood supply. There's a lot of research now going on to try and identify the specific metabolism of the cancer cell to target that, to try and prevent liver cancer. So when we manage a patient with liver cancer, obviously we want to have the patient at the center, and all of these people are equally important. Very often, the cancer care for a liver cancer patient is coordinated by a liver specialist, but a very, very important member of that team is the nurse coordinator. And I would dare say that most patients with liver cancer will understand more about their disease and their management and would be cared for by their nurse coordinator. But it's not just these two that manage liver cancer. We need good X-ray people. We might need pathologists to look at the biopsy. We might need different people to burn the cancer or freeze the cancer. We might need surgeons, transplant doctors. Sometimes we give radiation. Sometimes we give medical oncology drugs. And sometimes at some stage, our patients may need palliative care. And also, obviously, we have clinical trials. So I think the best management for liver cancer, if it's done as part of this multidisciplinary team, and it is worthwhile if you've got access, if you live in a city, to find a center that does MDT care for patients with liver cancer, because that's your best hope of getting access to all the treatments potentially available, as well as clinical trials. So if we were going to give drug therapy, general principles, we say if you're going to give drug therapy, it should only occur in the context of a multidisciplinary team. Patients should have early liver disease, because if you've got very advanced liver disease, your liver may not be able to tolerate it. When we talk about ECOG, it's basically talking about your function. Can you do everything at work? Are you bedridden on the one hand, or are you still going to work? So we want to get a person that's diagnosed early, that's got good liver function, and is basically doing most of his activities of daily living. And we want to reserve some of these treatments for cancers that we can't cure by cutting them out or burning them or freezing. We always believe that it should be done by an experienced doctor with experience in managing liver cancer. And because many of these drugs that we use, not only do we have to worry about the toxicity of the drug in general, we have to worry about adverse effects, even on the liver, because often the liver is quite diseased. And all treatment decisions should be coordinated, as I said, by that multidisciplinary team. The last few slides, I'm just going to talk very briefly about the treatments that we have. So this is a complex slide, but this is really trying to show you the two drugs that we have, sorafenib and lenvatinib. These are the two drugs that were used before immunotherapy came. And what they do is that every cancer cell has got these receptors that are illustrated by these inverted Ys up there. And what these drugs, all of these cancer drugs do, is they bind to the drug and bind to this receptor and stops the cancer cell multiplying. So all of these, what we call anti-VEGF drugs, like lenvatinib and sorafenib, they stop the cancer cell from multiplying, and they also block off the blood vessels to the cancer. Okay, so it's getting rid of the nutrient supply. And then you've got these immunotherapy drugs that are listed here. And what they do is they stimulate the immune system, which is the other part of the pathway I mentioned, actually kill the cancer cell. So in Australia, currently, we have 3 options for unresectable liver cancer: lenvatinib, sorafenib. So both of them are what I said, anti-VEGF, which means they stop the cell multiplying and they cut off the blood supply. And then we've got atezo-bev, and the bev part of it is the same as these drugs, block off the blood supply to the tumor and prevent it multiplying. And this one is the immune stimulant to try and get your own immune system to try and find the cancer cell and to kill it. And then if you look at the data, these are a couple of the trials. So this was the first trial that was done in patients who did not get any treatment. They used to live for about, on average, about 8 months. And if you took sorafenib, you lived for an extra 3 months on average. This trial was done much later, and this compared sorafenib and lenvatinib. And you can see we got better at treating because we were treating patients in MDTs. And you can see these 2 drugs are exactly the same, sorafenib and lenvatinib. Between 2007 and 2017, you can see the survival had improved from about 10 months here to about 13 months. And then with this new treatment, this atezo-bev, we pushed that survival up. So this is immunotherapy, and this is the treatment that we had in 2007, sorafenib. We pushed it up to 18 months. So we've moved from no drug treatment at 8 months, moving it to 11 months, then to 13 months, and now to 18 months treatment survival. However, as I mentioned, all these drugs have side effects, and we have our nurse educators who really spend a lot of time going through all the side effects. Blood pressure is very common, diarrhea can happen, fatigue, peeing out a bit of protein in your urine, thyroid problems. And you can also get something called, you can get skin rashes, which we talk about as hand-foot syndrome, because typically you get skin rashes on your hand and on your feet. But there are a few side effects, and these treatments are not for everyone. And your best ability to get on these treatments is diagnosing the cancers early by knowing that you have liver disease and getting monitored for it. And you can see, for example, in this one, high blood pressure occurs in up to 42%. So 1 in 2 people may get blood pressure. Skin rashes up to 50%. So these are actually quite common. And then the immuno-oncology treatment, with the immunotherapy drugs, you can also get side effects because you're stimulating your immune system. You can get inflammation of any organ in the body. So you can get an overactive thyroid, you can get lung disease, you can get a flare of hepatitis because basically it's stimulating the immune system. There are some newer clinical trials. So we're not just waiting to just give the treatments that we have now. We're thinking of various treatments. We're trying to give chemotherapy with radiotherapy beads into the liver. We're trying to mix drugs with microwave ablation to burn the tumor, or we're trying to give radioactive spheres. So there's a whole lot of active research. And if you're in an MDT, and if you're suitable, we might say, this is what we've got clinical trials, and you might even consider going on clinical trials. So finally, just to talk about what we can do about some of the symptoms of liver cancer. If you have liver cancer and you've got symptoms for weight loss, the important thing is we tend to refer to a dietitian. It's important to eat a healthy diet. It's important to eat plenty of protein. And it's important to exercise, because exercise and maintaining your muscle mass allows you to resist not only the side effects of chemotherapy, but it also stimulates your immune system to be better to fight the cancer. And then we've got specific things that we talk about for loss of appetite. For example, eating more frequent meals, but smaller meats, eating what you like rather than things that you don't like. We can give you pain relief if you need it. We've got drugs for nausea and fatigue. If you've got fluid in the belly, we can remove it. And then many of these drugs, as I said, can give you an itch and skin rashes. And I don't know if you can see that, but some of the things that we do, itch is not very common as a primary symptom of liver cancer. But some of the drugs that we have can cause an itch. Remember that your skin secretes oil every day to keep it nice and waterproof. And if you remember in dry weather or winter, a lot of us get itchy. And it's a bit more a severe reaction when you get these skin rashes from these drugs. So what we tend to do, what I tell patients if they get an itch from these drugs, tell them to have short showers. Don't use soap because you're removing all the oil from your skin. Use something like a QV cream or a non-soap cream. As soon as you finish your shower, and maybe twice a day, use Nivea cream or some other body lotion to keep your skin moist. If you have a shower, try and do it in a lukewarm temperature, because if you have a very hot shower, you're more likely to remove the oil from your skin. And then there are some drugs that your nurse practitioner or your doctor can prescribe to you. And there's a whole lot that I won't actually go through. But there are some medications that we can use to control your symptoms.